Good morning. Thank you for coming. Welcome to the first invited talk of the new Taming the Data invited speaker series that is sponsored by Cisco, EMC, Premier Healthcare Alliance, SAS, ePartners Program, and NC State Engineering Foundation. So this series is, what we're trying to do here is we're trying to make sense of the big data that is all around us. And today's speaker, Ms. Denise Hatzidakis, who will be talking about transforming healthcare through collaboration. So this is a wonderful example of how you can start addressing a challenging problem of what you do with your data, how you understand your data. Ms. Hatzidakis is an accomplished executive who has been solving challenging problems throughout her career. And today he will be talking about one such problem in healthcare.
Yeah, thank you, Rada. Thank you, and again, thank you for coming at 9:30 in the morning on a Friday. I was telling Rada before that I too am not a morning person until I started this job. I never thought there'd be a day in my life I woke up at 5:30 in the morning without an alarm. It's like against my religion. So let's get started. What I'm going to do this morning is talk through kind of who we are, what we do, and my intent is to give you some background or some thoughts around the stuff you're doing here every day and how it gets applied in the real world, and some of the not the academia is not the real world, but how it gets applied outside of the research work and stuff that you do, and especially how it applies to healthcare. So I want to start with just kind of a couple of statistics. There was a study done by the Joint Commission that told us that 80% of serious medical errors involve miscommunications. 80% of the medical errors are miscommunications. Right? And the problem and what causes these is literally the handoff of information. Right? 80% of the serious medical errors are because of the handoff of information. Even worse than that, it costs us $800 billion with a B dollars a year. Right? It's a serious problem and one that's fairly easy to fix if we can take the data, turn it into information, and make that information available at the right time to the right person in the right place so that they can act on it, right? But think about it. You go to the doctor. I went the other day. I messed up my shoulder, and I filled out, you get the clipboard when you get there, right? You fill out 5 pieces of paper, and you probably write your name and address at least 5 or 6 times, right? You're like, okay, don't you already have my name and address? Because I gave it to you when I called and made the appointment, right? So as simple as that to as complex as being in the operating room and collecting that data, because there's also a lot of what we're going to talk today is applicable outside of healthcare, but specifically in healthcare, the challenge is also just getting the data. And that's why big data and that kind of stuff is very, very relevant. A lot of data in healthcare specifically is handwritten notes, right? And then you put on the infamous Dr. Scribble on top of that, right? And mining big data and also getting information about patients and what they do outside of the provider environment, right? And we'll talk about continuum of care and where healthcare is going in just a second. The challenge in healthcare is really twofold, right? The government's kind of hedged their bets and said, okay, we're going to drive down costs, fee for service, right? Which is, you get paid when you provide service, but keep it as cost conscious as you can. And the other side, they've said, oh yeah, but by the way, we can't go at this rate in healthcare and spend this kind of money. So we need you to disrupt, we need you to innovate in care models, right? Innovate around the care models. So if you think about it, when you're trying to, if you're trying to do something with a minimal amount of stuff, right, which is the fee-for-service side of the house, how do you innovate, right? To innovate, you got to invest, right? You got to do some research, and you got to do some, to figure out, you got to try a few things, right? And so the challenge that we have in healthcare, which is not, it's especially bad in healthcare right now, but it's not unique to just the healthcare industry, is if you're trying to keep down costs, right, given the economy we're on, how do you keep down costs and still yet innovate and provide new care models? And a key driver in that is data. Healthcare itself is a very special industry for a couple other reasons, right? One is personal and emotional, right? While finance is personal and emotional, if you happen to lose a little money, it's not necessarily life-threatening, right? The other part of that is it's a form of public infrastructure. We don't think about it that way, but you think about things like pandemics, stability, mobility, productivity of an economy. Healthcare is a key piece of that. The bigger thing about it from a business perspective that makes healthcare really hard is there's not a constant demand model. right? Even in retail, when you have the spikes of the season, everybody goes Christmas shopping, it's kind of predictable, right? In healthcare, how do you predict people are going to be sick? So when it comes to keeping costs down, you don't want people to come to the hospital and not have medical supplies available, so you kind of got to overstock. But if you get the data and get the information to the point that you can make it predictable, right, it will go a long way to helping make that more effective and more efficient. So it doesn't adhere to the standard demand and supply. The other thing about it is, so the big thing about it is, what is the new normal in healthcare? Right? It's about turning data into actionable insight and information and making it available to the right person, the right time, in the right place. Right? That sounds like a lot of marketing, but it's really what it is. Right? How do we take the lessons learned that we have in the industry and apply them, right? Use things like social business. Use things like, you know, my daughter, she's 7, she doesn't think twice. My mom's over helping her do homework. Oh, I'll just go Google that. Or my mom's trying to find the encyclopedias and they don't even exist in the house anymore, right? Big shift in how this technology applies and how things are going to behave. And how do we integrate that into our systems? But it goes back to information's right here. Right? We got it all right here in our hand. Right? How do you get the right information there to affect change in any industry? So what Premier does is we focus on performance improvement in healthcare. Right? So a lot of the stuff we just talked about, our job is to help our members, and I'll talk about our membership in a second, do performance improvement. It may be in cost, it may be in efficacy of care, it may be in protocol, it may be, but really in this disruptive space. Right? But the problem isn't data. We got lots of data. Right? I have one out of every 4 discharges in the U.S. is refreshed in my database every 30 days, along with all the financial, operational, supply chain history with that. I can do a lot of stuff. Right? I can do this knee replacement costs twice of this one, but it's worth investing in this one because, look, the efficacy of care is higher. Right? The total stay is shorter, or the infection rate is lower. Right? So it's worth that investment up front. But if we go back to that picture of saving cost versus that, where are we going to go by default? We're going to get the cheaper one, which is really going to cost us more in the long run. Right? So it goes back to getting the data and turning that into information and predictive information, if we can. Right? So it's about turning that data into information, which is where a lot of the research and a lot of stuff that you guys do here is hugely relevant to those of us in the industry that are trying to solve these problems. Right? We don't have the bandwidth and the flexibility to go out and research and how do you do things. I was talking to Radha about, we are working with IBM on the first at-scale payer-provider supply chain data model in the industry. Right? And, but one of the things we don't have the ability to do is, how's that model going to perform? Right? It's one thing when you're running half a dozen streams of data through it, all that data I just talked about. When you scale it to the size of the data we have, right, I can put a lot of performance stuff on top of it, but if the model and the data doesn't perform well, and I can't turn that into these insights, it doesn't matter. Right? I can build a bunch of bright, sexy widgets to put on top, but if the data under it sucks, so what? If the information is not valid or reliable, it doesn't matter how great it is. It doesn't matter if it's an app on your phone or, you know, the biggest virtual thing that you see in the sky. Right? If the data and the information under it isn't good, it really doesn't matter. Right? So it really all starts with the kind of work that you folks do. So just a little bit more about Premier in general to give you an idea of the size and scale that we're dealing with. We're associated, we are a for-profit owned by 200 non-for-profit hospital systems in the country. We have 2,600 member hospitals and over 83,000 non-acute care sites that feed us data on a daily, monthly, quarterly, whatever appropriate is. We do I lost the number. Anyway, 43 billion, right, in group purchasing. The key one is up here. We have 4.2 billion documented savings just in 2011 off the work we've done, right? And we'll show you how we do some of that work. But the bottom line is we can document savings. We actually, when we go out to work with our members, we identify the opportunities, then we go to our member hospitals and say, okay, here's your opportunity. We actually help them implement it. And when we go in and implement it, we're so sure that we can generate those savings that we go at risk, right? We can go at risk and say, if you don't save $2 million, we're all in. That's how sure we are about it with the data we have. But the challenge with that is, how do we get that even bigger? Yeah.
How does this work then? Is you are for profit, and where do your profits go? The non-profits?
Yeah. So essentially, it's an interesting business model, right? So it's what happens is we keep the question, if you didn't hear, was how does it work? And we have profit and we have nonprofits, right? The way it basically works is that we keep enough money to run our business, and the rest goes back to our members. So we give back up to 70 cents on a dollar that we make back to our members. But the good thing about that is, when we go to take on an initiative that I'm getting ready to describe to you, our members, it's just like we're building an application and throwing it against the wall to see if it sticks, right? Our members are funding it, right? Our customers are funding us to actually do the work. So we know what we're doing. We'll talk about the collaborative methodology we use to build. But it's an interesting, took me a bit to get my head around it when I first heard about it. It's an interesting business model, but it totally works. Yes, sir.
Are any of our hospitals around here in the Alliance?
UNC and Duke or not. Okay. We're working with them on some initiatives, and in our conjunction with IBM, and our partnership with them has allowed us to do some work there. There's several big hospital systems in Charlotte, and so there are North Carolina hospitals. Okay. They're in, I don't have the 2,600 memorized, but since I live here in North Carolina, as you guys do, I know some of the ones in here. The big one in the area is Carolina's healthcare system, which is based out of Charlotte.
Okay.
So if you look at why this data and why this information is really relevant, if you take healthcare and where healthcare has grown up, so back in the day, performance improvement healthcare was about saving money, right? It was about how do you figure out how to, it was about the power of aggregate buying, right? It's called group purchasing, right? When a bunch of people get together, I can't drive down the price by myself, but if I get 10 of my friends to do it too, we can get a better price as an aggregate. Right? So we grew up, that was the first evolution in 40 years ago, performance improvement in healthcare was about saving money. So we grew up, we started as a group purchasing organization. We then moved to, as healthcare grew, the next thing is, so where's the next place you save money? Well, it's in process. So we started doing a lot of process improvement work. So we took that supply chain work and added process improvement on top of it. You drive efficiencies in supply, in processes. And then the next evolution is then how do you marry that to evidence-based? How do you make sure that those processes you're doing are not impacting outcomes, right? Or they're actually improving outcomes, back to that knee replacement example, right? How do you make sure that they are, you're driving, the things you're doing are actually driving better care? So now, you're layering kind of the next piece of the puzzle as healthcare has evolved, right? We then move to, where we move to now is a concept called bundled payments, which says if I'm gonna sign up for a certain reimbursement based on a DRG, and a DRG is essentially a diagnosis code, right? So I'm going to sign up for, I can treat a diabetic patient for X, right? So now I'm starting to go on my business model. Remember the business model we talked about? I'm starting to go at risk. So I better have some really good data and information if I'm going to keep my business whole, if I'm going to start doing that. The next evolution where we really are right now is population health, which is right here. What that's about, that's the next evolution, and where we're working really hard right now with our members is, how do you keep a population healthy? Now think about that business model we talked about, right? If I'm getting paid when people walk in my door, and now I'm being incented to keep people healthy, people aren't walking in my door. I'm not making money. How am I going to make this all work, right? So that's where the data and the information, especially the predictiveness of data, and some of the big data things that you guys are learning about and working on becomes extremely relevant, right? So even though it's about the business model, right, it's about using that data, using that information to keep things to drive change and manage populations, right? And it's about things like, it's also getting outside the care setting, right? It's about, gee, I told that diabetic that they needed to go exercise 3 times a week. Can I get the information from the Y? Can I look at their Twitter feed because they told their friends they went to the gym? right? Data starts coming from a lot of really interesting places. Have you guys heard the story about Target? There's a gentleman who called Target very, very dismayed because they were sending his daughter information on deals on pregnancy diapers, stuff like that. Very, very upset. Why are you sending this? Your targeting, your marketing is off. Well, it turns out that's how he found out his daughter was pregnant. Right? Now, how did Target know? There was no healthcare data. Our data is so locked down, and we'll talk in a minute about some of the challenges that we have there. But the data and the information and the analytics is so good that they could predict with her buying patterns that she was pregnant and when the baby was probably due. And believe it or not, they're actually fairly reliable on other stuff. Right? There was other data that came into it, but there's a lot of, so you get, that's not even healthcare data, right? That's so you look at if that kind of data is out there, right? How do you then how do you get that married with healthcare data? Think about how powerful some of that stuff would be. So you get outside of the care setting and outside of the payer and the provider data. Right? You get social data that starts to come in.
Excuse me.
Yes, sir.
When you show that model is evolving from group buying, and where are you at? I assume you don't make a lot on the group buying. That's old. Are you spending most of your time on the big data, or are you still doing the management of the disease kind of thing? Or?
From a business model or from an investment in technology?
From an investment in technology.
Investment in technology, 100% right here. Right. This stuff didn't go away. This is still significant. Right? This is hugely significant. Right? But it goes back to that layering, right? You don't do this one effectively without doing the one effective before it effectively. Right? So it's not okay, leave this one behind and then do this one. It's how you, which is where it really is, you think of the model in the travel industry, right? First you had to call to make a plane reservation, right? Then the airlines had websites. Each individual airline had a website, right? Okay, now we say, okay, that's good, but now I got to go to every one. So you get things like Expedia and Orbitz, right? So next level of aggregation. Well, now you got Kayak, who aggregates the aggregators, right? And recommends 10 things if I'm going to San Francisco, what they want me to do, and the best hotel deals, even though I wasn't looking for a hotel deal, right? Healthcare is kind of taking that same work. Healthcare, I've done this in finance and done it in retail. I'll tell you, healthcare is fairly far behind when it comes to technology. But it's that same concept of building and the aggregating of the data for higher and higher value information. I mean, because you look at, it's just like now, you'll get, when you go on to Facebook and Twitter and some of those places, they know where you are and what you're doing. They're recommending stuff based on where you are, right? I have my little simple weather app that follows me around the world that tells me whether I need to put on a coat in the morning or not, right? It's pretty amazing how the problem is, like I said at the beginning, the problem is not data, but we have a lot of data. It's how do we turn that data into information, and then how do we make that information actionable? So we talked about the collaborative methodology a little bit earlier. Basically, the way we do a lot of this work is we sit down with our members in a room and say, okay, here's where we are. What do you need next? Right? We help our members move on this continuum. So it's really, I think co-op for healthcare is really a lot of what we are. So just to give you a little idea, to make it a little bit more concrete through this evolution, what we've been able to drive. We talked about the process-based stuff. You can't read this, it's a little bit of an eye chart. But some of our data from evidence-based care improvements, right? 26% improvement, 59% improvement, 68% improvement, right? And in the number of people that were getting evidence-based care across our hospitals that participated in this collaborative. It gets even better if you look at some of these. Our next one was, and the big thing on this one for me, there's a lot of good numbers on here. The big thing for me here is if all hospitals achieve these results, if all the hospitals in the U.S. achieve these results, we'd save 63,000 lives a year and $23 billion in healthcare. That's annually. $23 billion annually. Seems like a no-brainer, right? I'm going to save 63,000 lives, sign me up. Right? I want to save that much money, sign me up. Right? My chief financial officer would love it if I told him I was saving that kind of money. What's the problem? You got to drive change with that information. Right? You got to take the data that generated this and get it into the right hands of the right people to drive that change. Right? And back to that back to the business model we talked about at the beginning, we don't have, as a system and in the economy in general, the ability to innovate. And this is not only the hard part that we forget, is it's not just, we need the information to help drive change, right? Because we change, the hard part of this isn't technology and driving this change, the hard part's culture and process, yeah.
So who at the hospital is that person that you need to change their mindset? Is it financial, medical, both?
All right, so the question is, who in the hospital do we need to get to change? It's really across the continuum. It's hospitals, healthcare is still very, very siloed, right, to where you've got the supply chain folks over here, the materials manager over here, you've got the chief medical officer here, and they really don't talk a lot, right? So there's some very simple connections that can be made to drive change. But it goes down to protocol all the way down to the bedside, because you can't create information out of the data if you don't get the data, right? So things like implant registries. Think about it. If you want to do an implant registry, and that means you got to have the implant logged on the sheet, right? You got to have the information of, or recalls, right? We hear recalls about body joints or something that are bad, or whatever. If you're lucky, before the procedure, and it gets all written down and all cataloged, ready to go, which it most likely does, what happens when you get in the middle of that procedure and something changes and you got to use a different one? How do you capture that data? It's not easy, right? You have to stop in the middle of somebody's hip wide open and write down a different number, right? So there's a lot of challenges. So it really goes, it's the whole continuum. It's all the way up to the executive layer. But you could imagine a scenario, something like, if you identify an opportunity, so say we identify an opportunity that there's some amount of savings in in this drug. You know, the way you drive change is through benchmarks, right? So we have all this data, we do a lot of benchmarking. So we can say you're above or below that benchmark. You know, you're spending way more on this drug than all the other hospitals like you are spending. So you should go. Well, the materials manager's looking at that. But you can imagine, but the materials manager, and you could drill all the way down to say, you know, Dr. Joe was spending 3 times on this as anybody else in the hospital, and he's way above the benchmark in the industry. Okay, got it. Now what do I do? And the person who identifies it, he's the supply chain guy. All he cares is about buying stuff and making sure there's stuff in the OR. He can't make a judgment as to whether that's good or bad that this doctor's overutilizing this particular medicine, right? Because it may be that Dr. Joe's just using a lot because the sales girl has a cute skirt. Right? Could be. Could also be that he's using a lot because he's found a new way to use the drug that's a whole lot more effective. Right? But you get in the case, here's a supply chain guy looking at the information. But you got the person way over here, not even connected, don't even think the same, right? You got a business person and a medical person. They don't even think the same. How do you get them and get that information connected? So it goes back to the value of bringing this information together, right? And the value we can drive out of it through some of the techniques that you're working on in research here and that you're studying in your classes about how do you make this information valuable? Does that make sense? There's a question? So you asked where we are now. We're at the population health space. So basically what we did, we looked, we stepped back about 2.5 years ago and said, my boss, who's a senior VP at the company, said, okay, here's where we are, here's where we got to go, how are we going to get there? We got all this data. It's very siloed, very, very siloed, right? And in fact, we're getting the same data from the same hospital more than once. In some cases, we don't even know it. Right? You go, gosh, why would you do that? Well, it's the way you grow up, right? You build the piece you have, and you go and you build the next piece, right? It's business layered on top of IT, and what does it drive in IT implementation, right? So we kind of said, gosh, we're going to have to blow this up and start over. We combine that with the fact that our members are constantly telling us, you've got our data, just tell us what to do, right? Tell us what to do. But the advantage, the flip side of that is, okay, it's one thing if I give you a spreadsheet, and I've got these 5 benchmarks, and this one's red, this one's yellow, this one's green. Okay. Help me know what to do about it, right? Connect that to the most relevant papers in the industry about people who are driving down cardiac or improving cardiac care. And get me to the guy who's the top in the country doing that so I can talk to him. I want my hospital to be the best. Another interesting thing about our business model is we're actually incented by our members being the top 25% of performing hospitals in the country. So now you get kind of that layer that social on top of data, right? I often, that's why we talk about, when I title my talks with collaboration, people who do data go, oh great, they're going to go talk about social business because that's all anybody cares about now, right? But it really is, how do you layer that on top of the information and drive it into this actionable, this space of putting it in the right hands at the right place, right? So what we said about is we kind of said, gosh, we got to blow it up and start it over. So about 2.5 years ago, 2 years ago now, we said, okay, we're going to build a net new platform from the ground up. So we're going to go out and find the best technologies and do this, because there was no way we were going to be able to bring together the data we have, right? We have it, and we can do a lot of really good things with it now. But for example, our supply chain data is in one place, and our quality data is in another. We can crosswalk it, and we do all kinds of stuff, but not nearly as efficiently and effectively as we can to scale and really drive it into a predictive form. So we started, so our mission in my group, which is the information technology and services space, is to provide a flexible integrated technology platform. There's a lot of words. Provide a flexible integrated technology platform that enables and automates the evolving activities of the Premier Alliance. In other words, how do we create a surveillance platform? And by that we mean a platform that when opportunities are identified, they're pushed out to the right person with all the best information we have that's available in the industry to connect it, right? So I'm marrying together data, I'm marrying together content, think enterprise content management, think roles and responsibilities, right? How do I know who you are when you log on? And how do I connect your data? And then how do I connect your data outside of the payer or even the provider continuum, right? Back to our example about the diabetic going to exercise, right? How do I marry that data into that to really get, because really what I need to be able to see to drive this is the continuum of care, right? I want to see, instead of treating you episodically, right? You have a broken arm, and then you broke your leg, and then you broke your knee. Those aren't connected. The real problem might be you have an autoimmune issue. But if those things aren't connected, how do we really treat, how do we get that whole continuum of care of information? So we started on this, this platform. I'll tell you a little bit about it. It's called the Premier Connect platform. It's essentially about, we've talked about how do we marry together actionable data, best practices, content, and collaboration tools. Right? So not only do we marry it together and give it to them, but how do we create a platform for them to innovate on? Right? How do we get all this information and data in such a way that they can actually innovate on it and share? Right? Because it's really a 1 + 1 = 3 kind of thing. Right? No one entity is going to solve this. That's true for any industry. Right? I'm very attached to healthcare, but it's true. You know, if I think about my financial, when I've done these kind of things in financial, I've done it in retail. It's the same kind of thing. When an industry is trying to innovate, no one entity is going to solve it, right? It's really the aggregate. So how do you enable the aggregate? Yes, sir.
So in here, I mean, I'm wondering whether you've got information flowing back. So if there's
Absolutely.
something that looks best, you know, some population, somebody out there in the field may say this is actually 3 subpopulations and this doesn't make sense for...
Absolutely. So there's research work around how do you stratify a population. There's this a question we're trying to figure out. What's the right way to, or what is a population? How do you define a population? What are the right attributes? What are the right metrics? Right? Carolina's Healthcare did some interesting work around, they brought in not only their data they had as a provider, they brought in data from, they brought in crime rates, they brought in socioeconomic status, they brought in ER visits, unnecessary, you know, preventable ER visits, etc. They identified a small group in Charlotte. They brought in a lot of other socioeconomic data into it. Identified a small place in Charlotte where it was a bunch of folks who worked minimum wage jobs. So part of the problem was they're not going to go, they can't take time off work to go to the doctor, right? So they're going to go when they're sick, which is much more expensive than getting in a preventative case, but they're not going to take off time to go to do preventative work. That's time they don't get paid, right? They set up a clinic in a local elementary school on a Saturday, because this data said, I can prevent a lot of stuff if I do this. Set it up, and I forget all the numbers, but they they identified 3 or 4 pre-hypertension cases. And this was just in one Saturday in 4 hours. They got under, I think it was 2 or 3 prenatal care, women who probably would have never gone until they had the baby, right, to make sure the babies are getting good care. And there's a whole thing of things that just by getting all that information and all that data, aggregating it and identifying that, and saying, oh, we could do something here for this population that makes a big difference. So it manifests itself that way. It also manifests itself in how does Carolinas now help other people do that, right? So what we do as an alliance is Carolinas and a couple other hospitals are now getting together because we've got a couple other hospitals or hospital systems that have used other types of data to identify populations. So what are the ones that really worked and what they didn't? But you can imagine if they went off and did it in isolation, it's going to take them a whole lot longer to get to the same place, right? So that's where this aggregate 1 + 1 = 3. And what we do as an alliance is to facilitate that collaboration. Does that make sense? So it's about connecting data, connecting knowledge, and connecting people. So we built a platform, and really, it's social business meets analytics, right? So essentially, we rebuilt LinkedIn and Twitter for healthcare. Now, why did we not use Twitter and LinkedIn that are out there today?
Privacy issues.
Privacy, security, there's a lot of issues, right? We have, my chief security officer tells me every week I won't look good in orange. Right? He wants to keep reminding me that orange or stripes would not work well for me. And it's because we have a lot of challenges with our data, right? So we have a lot of things, too, that are difficult in healthcare. It's not only privacy, right, which is de-identified data. There's a lot of rules around you being able to be identified by your particular data. There's also rules when you're doing statistics about being statistically significant that are extra challenging in healthcare. But it gets even better than that, right? It's I got to make sure that only you as a system see only your data. Also, there are data sharing agreements that layer on top of that. So it's just not plain security. It's not just, I know you're the chief medical officer for Duke Healthcare, and so you can only see Duke Healthcare information. There's data sharing agreements that get signed within the hospital. Worse than that, there's data sharing agreements that get signed between systems, right? So Duke may say it's going to share information with UNC or with Geisinger or Mayo or whoever. So I got to affect that on top of it. So I've got situations, for example, we have a physician profiling tool that shows how well physicians perform across. But if I've got 2 hospitals that don't have a data sharing agreement, and that physician practices at both of those hospitals, I can tell you, but I can't tell you because those 2 hospitals said they wouldn't share information, right? There's things like we get Medicare information from CMS, and I got a lot of rich I can join out of that. There are rules around how I can join that with publicly available data. Right? So there's a lot of, you're very hamstrung by how you can connect that. Not only that, because of the benchmarking and peer grouping that we do, I can, for different situations and different information that I want to look at, right? I can change dynamically on the fly who I want to compare myself with. Right? So for one metric, I can say I want to look at how I compare to Mayo or Geisinger or UNC, and for another, it might be Carolinas or Texas Health Resources or Fairview. Right? On the fly, I can decide this. So it puts a whole nother metric, which you can imagine what that does to your analytics. Right? You can't just have them all built sitting on the shelf waiting for them to pop out, right? It's not a matter of I got them all built, call me and I'll give you your report, right? It's all got to be, which goes back to that data model and that core piece that it's got to perform from the ground up. You've got to be able to do so. It's not only just harvesting the information out of the data, but how do you harvest that in such a way that it's actionable? Right? Some things it's okay. Retrospective analysis doesn't go away. There's a ton of that that's hugely valuable. But how do you affect that in real time in some cases? We've got a safety surveillance product. Basically what it does is there's a box that sits in the hospital. It pulls data off what's called the HL7 hub. Right? HL7 is healthcare standards are interesting. It's a good suggestion. But it pulls data off that hub. And then in real time, tells an infection preventionist or a clinical pharmacist what's going on and sends alerts to affect care. Right? So it says, this person was admitted 6 weeks ago and they had this infection, you better check it when it comes in. Or this person didn't get aspirin within 24 hours. Or this was supposed to be checked and I haven't seen the lab test in the last 2 days or whatever the case is, right? So you get data that's as real time as that, all the way to the other end, which is the retrospective analysis that we know and classically think of as analytics. So these are just some screenshots of what the front end of it looks like. It's really fairly simple. It's actions or stuff that I'm pushing out for you to take action on. Knowledge is knowledge. Information, stuff that we found, and communities are where we do our collaboration. We do our collaboration work. So if you've been on Twitter or LinkedIn or somewhere like that, none of this is going to be rocket science, right? This is pretty basic. What's relevant and what makes it different for us is having that information and being able to get that information into a form that's actionable. So, for example, we push out contract analytics. So, for example, we identify that you're buying on one contract, but you could actually buy on this other contract and do better. Right? It's a fairly simple case, but then through this platform, we push that opportunity out directly to that person. Right? It's about how do we think about our work? Right? Think about your email. It's an action feed. It tells you go through your email. It's what you act on. Right? Just like Twitter, just like any of that. Right? So you take that whole model, very simple model, and lay it on top of this information. And that's what we talk about with social meets healthcare, or healthcare and analytics. So where this is really going, right? All that's really great, and that's kind of the as is. That's where we are. But we got to keep growing it. So where we are is we just launched. We have two pieces of our portfolio. Premier Connect is a brand. We have the Alliance version, which is really the free social platform. We give it to everybody in the Alliance who wants it. Everybody gets it. Select is essentially, think a la carte for analytical tools, or a la carte for tools, right? So that's where I can add and put tools on top of the platform to drive the information I want, to find the analytics, to do lots of things like that, which is great. But how do I facilitate this 1 + 1 = 3 in innovation? Because remember back to the very beginning, we talked about the challenge of fee-for-service and disruptive. We got to innovate care models. How do we build something? How do we do something that allows to create an innovation platform, right? So where we are right now is working on something we call Premier Connect Enterprise. Essentially what that is it's a how do we take what we've built, make it available to our members, and facilitate an ecosystem in healthcare. Think Android or iOS for healthcare. Right? Put it out there so that people can build stuff and share it. How do you create something so maybe if somebody builds a nursing dashboard, Premier, we're not going to probably build a nursing dashboard, but you could imagine everybody else might want a nursing dashboard, but how do you make that work, right? From a technology perspective, healthcare is as diverse as it comes. I promise you, when I took over this IT shop, I think I had the best test bed for integrating any two technologies in the industry that ever existed, right?
And you like it.
Oh my gosh. But the problem with that is we're upside down in IT spend. Right? The problem with that is I'm spending so much resource making those things work together and talk to each other back to integrating that data that there's nothing left to innovate on top of it. Right? Our members have that same challenge. Right? So how do we provide and build an ecosystem, a platform, so that they can kind of get that leg up off of what we've already done and innovate on top of it? And it goes back to that data model. Right? So the integration really is not the technologies, it's the data model and the data. Right? So we partnered with IBM, as I said before, to build the first at-scale payer-provider supply chain data model, right? Which is the first model in the industry to be able to bring all this data together. Right? Premier is very, very fluent in the provider market. IBM is very, very fluent in the payer market. Right? So providers are people who give you care, payers are the insurance companies that pay you. Right? Then you have a real good picture, right? Because who has the most accurate picture of what's going on? It's the payer. They know exactly what they paid for and exactly because you want to get reimbursed for it, right? So bring those two together, and that's the integration layer. Fill it with whatever technology you want. Take it out with whatever technology you want. That's the integration layer. So it goes back to the discussion before about this data model and why the data and how we put the data together is so extremely critical to something like this being successful. And we can't sustain where healthcare is today. We've got to be able to make these changes, right? So, and the only way we're going to drive these changes back to is we saw the 63,000 lives and billions of dollars a year, right? We've got to get that information out, and we've got to get it shared, and we've got to get it. So you can imagine a scenario where if I'm not sharing the same platform, so I can say that, right? And any hospital that didn't participate in, they go, yeah, right. We all know data, we all know statistics, right? How much do you believe statistics? They're statistics, right? They're directionally correct. They can be very accurate, but if it's not my data and when there's lives on the line, right, there's lives at stake, you want to know that data is right, so you want it off your data, not somebody else's data that might give you a good idea. But it's one thing to go to Carfax and find out that, okay, everybody else who bought this car from this company like this, oh, okay, I'll give them a try. It's a different thing to find out everybody else used this drug to do this, and in their particular case, it didn't kill anybody. Right? Very different, same problem, very, very different scenario, right? Oops, wrong way. So, our most recent initiative is called the Data Alliance, right? Think co-op for data, right? So we're using all this technology and all the things that we talked about to create a co-op for data. We went to our members, like we did in that collaborative methodology, and said, okay, we built this platform, Alliance Select. What would be valuable to you next, right? So in the capacity of driving performance improvement in healthcare, they don't have the ability to stand up big IT shops, right? We invested a lot of money and a lot of time to build this new platform. So how do we give that to them in such a way that they can leverage it, right? And what our members said, give us that and build us a co-op for data. Right? Give us a way that we can exchange assets, right? So that we can get that 1 + 1 = 3. So our next evolution, this collaborative with our members, is the Data Alliance. And we actually today have, we talked about a lot about this, we actually have, there's two methodologies in which we've got four members right now that we're working with this. We'll have a few more by the end of the year. Carolinas Healthcare and Texas Health Resources, what they're doing, they've got the IT infrastructure. They want to build a private warehouse on site, right? But they want to take advantage, right, of that ecosystem. So through the data model, they can. They're building their on-site premised warehouses using this data model. We've also got two members that are doing what we call Premier Connect Enterprise, which is essentially a hosted data warehouse on the same data model, and we give them access to it to innovate. Right? Now we're creating an ecosystem for innovation around healthcare information. So that's really what we're doing and where we're going. Right? A lot of what came up to here led up to why we're doing it. Right? Because it's one thing for me to come in here and say, okay, we built this really cool warehouse platform and we're going to put it in the cloud. Right? You're not cool if you're not in the cloud. So what? Right? So the next phase of this is how do we then put an exchange on top of that? Right? How do we make it really easy for the members to exchange assets? Right? They might be applications like you get out of the App Store. They might just be assets. Right? If I've got an EMR, electronic medical record system, like Epic or Cerner or Clarity or whoever, right? And but there's lots of them out there. Back to that, you're not going to integrate the technologies. You got to integrate the information. So if you go to integrating the technologies, there may be assets. So if I got somebody over here as Epic and somebody and they figure out some assets to figure out how to map the data into the data, maybe they just want to share that mapping. That's an asset that could be exchanged. That still gives them a leg up because they don't have to go reinvent that from scratch. So the next phase of this for us going into 2014 is then how do we start facilitating this exchange, right? So it could be assets, it could be reports, it could be learnings, it could be lots of other types of things, right? So what we're facilitating, we've got the largest interconnected community of healthcare providers in the industry. I've got 80,000 unique IDs stood up on this platform today, right? It's growing every day. This is a picture from a video screen that stands in our lobby. The dots are people who are interfacing with the system. The size of the dot is the volume of the data that's going back and forth. Red, yellow, or green means the response times they're getting. Green means it's less than 5 seconds. Yellow, I think, means over 5 seconds but less than 10. And red means, and we've got it all instrumented to know whether it's our problem in-house, right? Because now, again, we're pushing analytics over infrastructure that we don't have control over, right? You know, think about it. Your computer works great till the internet goes down, but it's not your computer's problem. Right? It's the internet's problem. So another thing around this is analytics and information around analyzing these infrastructures to make sure we can keep the data. Unfortunately, I took this snapshot at about 10 o'clock at night. So it wasn't during the day. You'll see this thing light up and move around. And we have a ticker that goes across the bottom that tells us exactly how many requests and exactly what response time, just like a stock ticker. Are these people getting their data? Are they getting it in a timely fashion? Are they getting, et cetera? So, so basically, that's where I'll end with what we're doing is trying to facilitate the largest integrated network of hospitals, care, and information in the country. So that's all I have. Thank you.
Excellent, Denise. Questions?
Go graduate. I need lots of people who can do good work with data. Yeah.
Well, but, you know, not knowing a lot about, you know, as a user of the system, not knowing the data. The errors that were fixed, you know, when you started on your first slide, you said, well, we fixed these errors by communication. And most of those error fixes were when the nurse would repeat what the doctor said back to the doctor to make sure that, yes, that's what you wanted me to do. They were very simple solutions. They were writing on an arm, don't amputate this one. You know, the errors were simple solutions. Mm-hmm. And as we go through this and we talk about big data, we seem to be going to bigger, more, you know, but you want a targeted solution. Do you see that? It seems like a mismatch to me.
I'm not quite following. Keep going.
What I'm thinking is, had cancer. My
Right.
oncologist is looking at a certain picture of that data.
Absolutely.
He doesn't want this big ship of data. He wants his data. Do you know what I mean? And it seems like we build out in hospitals, we seem to build it out bigger and bigger and bigger, when really what we need is more targeted, more simple solutions.
Yeah, so exactly to your point. So, but I put a slightly different lens on it. Your oncologist wants that data, but he also wants any insights you can derive on that data, which aren't going to come from, some of the most useful insights don't come from just that data. It comes from the continuum of data, right? So it's to your point is exactly spot on, is that we got to connect all the data, but then we got to drive targeted insights out of it, right? It's not just dump, because my oncologist would be the same. He's like, I don't know all this, but I can tell you, from my perspective, being a cancer survivor, some of the best treatment I got was when they weren't looking at my oncology data, right? And the fact that when I go in for a hangnail, I just have a hangnail. My thumb's not going to fall off with a 5-inch tumor tomorrow. I just fix my thumb, right? So back to that, how do you get that insightful, how do you get that targeted insight? And the problem with that is right now, we don't have a lot of the technologies, the data and stuff connected to drive those targeted insights to your point. How do you get that? So you're spot on. But we have to do a little bit of this to be able to go here. And that's really the state, in healthcare, that's the state of the industry right now. Does that make sense?
Mm-hmm.
Next
questions?
Yanis?
So on the innovation part, Denise, how can we work together? We have a lot of students who come to me, for example, with brilliant, bright ideas or semi-brilliant ideas.
I like brilliant ideas. I'm all for brilliant ideas.
So how do we put this, let's say we have an idea on saving cost for the hospitals.
Mm-hmm.
Do we come to you and say, here's our idea, or?
Yeah, probably I'm your starting point. Yeah, probably I'm your starting point, and then I'll get you to the right place. Because, quite frankly, believe it or not, we're a 1,200-person company. We're not that big. And half of those people are out working with the members, and say, IT is only, we are 600 people. And of that, 300 of those people do nothing but cleanse data every day. So healthcare has some of the dirtiest data you'll ever see. So I have 300 people who sit in my building and bring that data in and get it right before we land it, right? Because if I'm going to do a comparison, I got to have all that data normalized at some level so I can compare it. So that comes down to I got 300 people building this system, keeping the ship running. So any opportunities to help get a 1 + 1 = 3 out of that, I would be very open to.
Goes the other way too. If we have some idea about a proposal and we need some data, or a prototype, or to back up some of our ideas, do you have any data you can make available?
We do have some data we can make available. We have a research arm that's not part of my group, that and we build a database for them that's a de-identified database. That's just statistically, that's why I'm not in data. I can't say statistically significant without tripping over my tongue. But that we can potentially make available for research purposes. I mean, there's a lot of usage stuff we still got to sign and all that, and that's why I have legal people with bigger brains than mine that can figure all that out. But we do have the ability to give data for things like that. Yeah.
Sounds like there's a big portion of your pain in the data cleansing. Are there any other significant needs that you may have right now?
Data cleansing and efficiency around data cleansing, we use a tool called Symmetrical right now to do some of the mapping, right, and building. And it's also, I talked to Rada a little bit about the data model itself that we have and doing work around how performant that data model is and what are the best ways to query and interact with that model, right? Because just building a model is great, right? But how normalized, how denormalized, should we aggregate it into dimensions in subject areas or I mean, what's the right way to interact with that information to act efficiently? Some of the other challenges are around then how do we connect that data and how do we see in real time without human intervention because of, oh, I saw this pattern in the data, this is what it means. So there's a significant part of pattern recognition that's a challenge, right? So how do you recognize the patterns in the data that indicate certain things, right? So it's one thing to roll it all up and do a calculation and come up with a comparative benchmark. Right? It's a different thing to see data trending somewhere proactively, and what are those? So that's another challenge we have right now is the ability and coming up with the ways to watch that data trending.
Do you have any concerns about outsourcing onshore, offshore to help you out with that kind of activity?
Me or my business? As a company, we have hesitated to do that, but only because we're a data development company, and we're growing into a technology savvy, and so while having done this I know I can keep my data safe and keep the data onshore. The actual work is still offshore. I've got to work getting my, but I'm open to helping entertain that, and I think one of the things that would help me drive that would be being obviously if I could show the business value of doing that, I could get a whole lot more attention to do that kind of model than just to say, okay, it would help if I put 5 people offshore to do the cleansing because they're cheaper. Right? That just really doesn't get me anywhere. Not in the business we're in. Does that make sense? Yeah.
Have you been working with like the common data model from OMA at all? Observational Medical Outcomes Partnership?
We have. There's several data models that were in the industry, and the ones IBM had, we basically took all of those and kind of put them together. Okay. And I've had a lot of SMEs in the industry. We haven't been as focused on the research aspects of the model, right? Our first was just getting all the clinical data and payer data and everything connected up, but we're starting to focus on some of the researchers where that will come back into play in a much bigger space. Like the genomics and stuff like that, very relevant. It's not that we don't care about it, but you gotta eat the elephant one bite at a time. If you take too many bites, you'll choke, right? And this is a darn big elephant. So, but yeah, we're bringing those standards in.
Are you participating in the common data model discussion that's out there?
We are, and we participate in a lot of standards, not only the data model standard stuff, but also standards around like GLN and UNSPSC and SNOMED, LOINC, a lot of the standards in the industry in general. ICD-10, ICD-9 is a lot of talk about that, right? And how do you connect those models? And another interesting thing about the model is, what do you do when you have a piece of data that's represented differently in 3 or 4 different standards?
That's my life.
Yes.
That's all I do all the time.
I have lots of use cases for you. So I mean, we've done it, right? But have we done it as efficiently and as effectively as we can? Hard to say, right? Because I also still got to run a business. My background is we'll code for food. I'd love to go sit in a corner and write code, but still got to run a business, right? So yeah, stuff like that is definitely of interest to us. So was that helpful? Does it help you understand does it kind of connect what you guys are doing every day to what we're doing outside these 4 walls? Great questions. Any other questions?
Thanks again, Denise.
Yeah, thank you. Anytime.